Intestinal obstruction is defined as restriction of the normal passage of intestinal contents, either due to a mechanical real obstruction or due to functional obstruction due to paralysis of the bowel, paralytic ileus. It is classified according to many parameters: speed of onset, size, nature, etiology, and age group. According to the speed of onset, it can be acute obstruction, which is rapid and severe, complete obstruction, which needs immediate attention. Subacute obstruction presents with non-specific symptoms with vague picture of abdominal pain and signs. And it might resolve spontaneously. The chronic constipation is a slowly growing intestinal obstruction, which is incomplete obstruction and develops over a longer time. The frank example of this one is carcinoma of the colon. Cancer colon presents with chronic intestinal obstruction rather than acute. Sometimes the incomplete obstruction become complete, and then it is an acute on top of chronic intestinal obstruction. It is classified into high and low obstruction. In a way, it's synonymous with small and large bowel obstruction, but not completely, because there might be a very low small bowel obstruction, which is still small bowel, not large bowel obstruction. The nature, the simple obstruction happens when the blood supply is still intact, while strangulated obstruction, which is the dangerous one, when the blood supply is compromised. So we are at risk of bowel gangrene, which is a very serious thing. This will be seen in strangulated hernia or volvulus or intersusception, sometimes due to damage. Gangrene is the result if this obstruction is not relieved very quickly. The etiology, it might be from inside the lumen or within the wall of the bowel or from outside. In the lumen, foreign body, the most important, the most common. And also intersusception, when some part of the bowel gets inside the next one. So it is in a way intraluminal. The wall, the pathologies in the wall, the inflammatory bowel disease and the neoplastic bowel disease, the tumors also, in addition to diverticulitis. Outside, the hernia. The most important example is the hernia. External or internal, volvulus and adhesions. These are the most common causes of intestinal obstruction in our practice. Hernia and adhesions. Adhesions number 1, hernia number 2. The age group, there are some specific types of intestinal obstruction known in special age groups. Neonatal intestinal obstruction has its own pathologies: atresia and stenosis, imperforate anus, volvulus, Hirschsprung. In infants, intersusception becomes the common cause, in addition to Hirschsprung disease and hernia. Hernia is a cause of some obstruction in all age groups. Young adults, mostly hernia and adhesion. The elderly, the diverticulitis and cancer colon are added. What happens in intestinal obstruction? There is an obstruction, so the bowel above this point of obstruction will have a accumulation of fluids and dilatation of its lumen. So we have dilated bowel above the point of obstruction, while the distal part, distal to this point of obstruction, will empty and collapse. The peristaltic movements, which is the physiological movements of the bowel to propel the contents of the bowel, needs to increase to overcome this obstruction. So we have exaggerated peristalsis, which will be reflected on pain, abdominal colic, and exaggerated bowel sound on auscultation. This is the most dangerous part of the some obstruction, the strangulation. When a part of the bowel is obstructed, we have two mechanisms to compromise its blood supply. The dilatation by itself of the loop of bowel will stretch the wall and result in gradual ischemia, which, if not treated at one stage, it will end with necrosis and perforation. And the outside pressure on this bowel, in case of strangulated hernia, for example, also will result in the compromising blood supply, and it will end with gangrene if not relieved very soon. In addition to this local effect, what is called mucosal barrier, which prevents the toxins and bacteria inside the lumen of the bowel to cross to the circulation, will be lost after ischemia. Then the bacteria will start to pass into circulation, what is called transudation. It will pass to the peritoneal cavity by transudation, and then to the bloodstream. And we will end with peritonitis. The gangrene also of the bowel, if not relieved, it will end with perforation and generalized peritonitis, in addition to this transudation. So, what is the lethal effect of intestinal obstruction? First, the fluid and electrolytes imbalance, and second, the toxemia and septicemia. What are the main cardinal symptoms of intestinal obstruction? Pain, colicky abdominal pain, number one. Vomiting, which will be more the higher the obstruction. Distension, which will be more the lower the obstruction. And an absolute constipation, mostly seen in large bowel obstruction, not in small bowel obstruction. Absolute constipation means constipation to both feces and flatus. It cannot pass anything. He will tell you that his abdomen is about to perforate because he cannot pass any flatus. Pain. This is the first symptom. Colicky in nature. What is the colicky in nature? Wax and wings. The colic comes with the peristaltic wave. It reaches a maximum and then it drops gradually and resolves. Sometimes there is a residual pain between the attacks above the baseline. The site is ill-localized, mainly central, and in cases of chronic obstruction, the patients describe it as suprapubic pain. The post-operative obstruction is painless. Remember, the paralytic ileus, which follows the operation, when the prolonged paralytic ileus is prolonged, this type of obstruction is painless. What makes the difficulty? The pain of the wound. So the patient will mix the abdominal pain from inside with the wound pain from outside. So you have to be very specific investigating this patient, this symptom. Vomiting in high obstruction is very early, it's very late in low obstruction. With time, with hours, this accumulated fluid in the bowel above the point of obstruction will become fermented, food will become fermented, and it will be badly smelly, feculent. It is called feculent because it looks like the smell of the feces, but it's not completely fecal. Remember, when you see vomiting completely fecal, this is not enough, the accumulation of fluids over time. It must, there must be an overlying fistula. Either cancer stomach fistulated into the transverse colon, or cancer colon fistulated into the stomach. This gastrocolic fistula will produce completely fecal vomiting. Abdominal distension, the more distal the obstruction, the more the distension. In high obstruction, there will be minimal abdominal distension. Absolute constipation, mainly in cancer colon. Examination. We finished history, we move to examination. I always tell my students, be systematic. In everything, be systematic. When you describe any disease, you talk about symptoms first, then you talk about the examination, signs, and lastly, the investigations to diagnose. So, the patient, on examination, also be systematic. We start with general conditions. The patient will look ill, in pain, and dehydrated. Next to general condition, vital signs. There will be tachycardia. Temperature will rise when start to have strangulation or sepsis in cases of perforation or peritonitis. So always, the raised temperature is an alarming symptom of strangulation or perforation. On local examination of the abdomen, on inspection, it will be distended abdomen, sometimes visible peristalsis. Visible peristalsis is not always pathological. In a thin patient can be seen normally. Then you will look for scars. Always, in case of obstruction, look for scars. In the history, you will ask the patient about any abdominal surgery, but also the patient may forget to tell you, look for scars in the abdomen. When you find a scar, most likely that some obstruction is adhesive. Look for hernial orifices in any obstruction. It's part of the abdominal examination, but especially in cases of some obstruction, look for the two most important common pathologies, adhesions and hernia. So look for scars in the abdomen and inspect all the hernial orifices very well. Of course, the strangulated hernia will not hide itself. The patient will come complaining of a painful irreducibility of this hernia. But sometimes in an obese patient, femoral hernia cannot be detected easily. It's small with the obesity, sometimes can be overlooked. So look for it. On palpation, next to inspection, on palpation, the abdomen is tender, generalized tenderness. But more or less, it will be soft in the initial period. If there is a guarding rigidity, this is an alarming symptom. And we have to consider perforation if the abdomen shows any rigidity. But generalized tenderness is usual in these cases, but without guarding. On percussion, hyper-resonant note. I always tell the students, the correct description of this sound is note. You see, you will describe this note as hyper-resonant. What is the usual, the normal one? Resonant. Usually it is resonant because all the time the bowel will have some air and some fluid together, which will produce this resonant note. But in intestinal obstruction, it will be over-distended with gas, and it will be hyper-resonant, which is probably say that. Auscultation, bowel sounds are exaggerated, of course, exaggerated bowel sounds, and more frequent. Usually, we wait for the bowel sound cycle. You will not hear it when you put your stethoscope immediately. You have to wait for the coming cycle, and then wait for the next cycle to see how much in between, usually about 3 cycles a minute. In external obstruction, it will be more frequent. You may find 6 cycles a minute, and at one stage, it will be after each other without any pause. Continuous. Rectal examination is part of the abdominal examination, especially in intestinal obstruction. You have to do BR examination for every patient complaining of intestinal obstruction. What do you want to see? Usually, you find empty rectum in cases of intestinal obstruction. Sometimes there is some residual stool below the obstruction, which will soon pass, and it will be empty rectum. Unless it's a case of fecal impulsion, of course. Strangulation happens when the blood supply is compromised, and you have to watch your patient to detect this as soon as possible. What happens with case of intestinal obstruction? We admit adhesive obstruction usually presents, as we said, with subacute intestinal obstruction. It's not so acute, but it's not chronic like the cancer colon. We start with conservative treatment, observing the patient, giving him IV fluids, sucking decompressing the upper part above the obstruction by NG tube, suck and drip. And we observe our patient closely to detect any possible strangulation or perforation. How we observe the patient? Again, systemically. Symptom-wise, history. The colicky pain changes to continuous stabbing, severe pain. The first colic pain is not that severe, but when we come to strangulation, the pain is severe and continuous. It's not colicky in attacks, but continuous pain. Why it's continuous severe pain? Because it's ischemia. The ischemic pain is the most severe pain in the body usually. This might not be completely felt by the patient, but it is associated with some peritonitis, and if there is perforation, there will be generalized peritonitis. So we observe the pain. Then the general condition of the patient. He was looking well, now he's looking ill, and he is in continuous severe pain, and he looks, it's described as toxic. He looks toxic. The toxic description is describing high fever with very ill patients. Temperature will start to raise with strangulation, and there will be tachycardia, and in advanced stage, he will be in complete shock. He will be shocked, septic shock. On local examination of the abdomen, you will have tenderness with rigidity now. Previously, there was some mild generalized tenderness. Now we have more tenderness with guarding, rigidity. If it is localized to one part, like acute appendicitis, it will be localized tenderness and guarding. But if there is a perforation and peritonitis started, then you will have generalized tenderness, severe tenderness, and guarding, rigid abdomen. Bowel sounds It was exaggerated before to overcome the obstruction, but with perforation, peritonitis, and sepsis, it will drop down until it's completely absent with complete picture of peritonitis and septicemia. The silent abdomen is a dangerous abdomen. This is advanced condition in this septicemia and peritonitis. There will be, of course, leukocytosis in investigations with neutrophilia. The plain X-ray is very valuable in this obstruction. It will show you the dilated loops and the erect fluid levels. We do erect and supine films. The supine film will show clearly the dilated loops and the size of these dilated loops, in which area of the abdomen, upper, lower, right, left. Yeah, it will give you a rough idea about the site of obstruction, and the erect one will show you the air fluid levels. Usually more than 5 air fluid levels is considered pathological, and dilated small bowel lumen more than 2.5 centimeters is considered pathological. Commonly it is asked which is more informative, the erect and or the supine film. The correct answer is the supine film. It's more informative. The erect film is good to show you that there is obstruction, but usually this is already diagnosed clinically. It will not add much. But the supine film will show you the dilated loops. Are they small bowel, large bowel, which area of the abdomen? It will be more useful, more informative to the surgeon. To differentiate between the loops of small bowel and the large bowel, usually the small bowel is central and the large bowel is peripheral. Of course, there is remote colon, it is more or less central also, you have to consider that. And the stria is complete in the small bowel. Across the whole width of the lumen makes a leather appearance, what's called leather pattern. While the large bowel will have hostrations of the T. ecoli, which will not cross the lumen completely, partly, only partly. In cases of closed loop obstruction, it will not show on the X-ray because it's full of fluid without any air, so you will not see the dilated loop and you will not see the air fluid. What are the examples of closed loop obstruction? Usually volvulus. Volvulus is most commonly seen in the sigmoid colon, but it happens in the small bowel when there is any tumor or band or something attached to a loop, then it will rotate around this axis. These are examples of the X-rays, simple X-ray abdomen. And the first one on the left shows the leather pattern of the small bowel, and the middle shows the air fluid levels, and on the right side, the large bowel dilatation and prostration incompletely crossing the lumen. The CT with contrast is the gold standard of diagnosing intestinal obstruction. The plain abdomen will give you an idea, will diagnose obstruction, but the CT will show you the exact pathology and its site, where it is. Of course, it will not give you an exact measurement, but it will tell you that it is in the distal small bowel, for example, or proximal small bowel, or in the middle, and it will show if there is a tumor or something like that. CT is done with IV contrast and oral contrast. In very distal obstruction like cancer colon, we can add a contrast enema also, making the CT triple contrast. IV contrast, oral contrast, and rectal contrast, which will show you exactly the obstructive lesion in the colon. The oral contrast, of course, will reach the end of the colon and it will show you grossly, but with this long passage, the 6 meters of small bowel and the large bowel, it will become at the end very dilute. So it will not be very well defined. While the contrast given from the rectum will be very specific and shows clearly the obstructive lesion. This is the CT scan with the oral contrast and IV contrast, showing dilated lobes, and the radiologist will follow this segment until he reaches the points of obstruction, and then he will tell you that there's an obstructive lesion at this level and so on. So, treatment. There are specific treatments for the specific pathology and generalized treatment plans. It follows the general principles of surgery. Always in acute obstruction, be careful about the risk of strangulation, and it should be managed quickly, like strangulated hernia, for example. It should be managed very quickly before you reach the gangrene of the body. Chronic obstruction will give you a chance to investigate and take your time to do planned surgery rather than emergency surgery, because it's usually incomplete. So this patient can be prepared and colonoscoped and biopsy, reaching a diagnosis, and we can assess the stage of the disease and then go with planned elective surgery. The usual treatment of the subacute intestinal obstruction is follows the advice of suck and drip. Suck to decompress the distended bowel. We said that this distension at one stage will cause ischemia by stretching the wall of the distended bowel. So we can help this bowel to recover by decompressing it with NG2. You put NG2 with suction or with gravity alone, and you give the patient enough IV fluids. To replace the lost fluid and electrolyte, and to maintain him because he is put NPO during this period of treatment. So you take consideration to deficit, how much there is deficit, and you give him enough maintenance fluids and electrolytes. I always tell the residents that they forget the potassium in our usual surgical practice, because most of our surgical patients do not need potassium in the early post-operative period, and they start oral feeding before they need it. This is why most of the residents forget sometimes giving potassium. They give only sodium requirement and fluid requirement, so saline, normal saline. So in these patients, you have to remember the potassium. You have to give maintenance, 60 to 80 milliequivalents per 24 hours for adults, 1 milliequivalent per kilogram per 24 hours, and replace if there is already deficit and the patient is already hypokalemic. Give him enough fluids. The maintenance is 2.5 to 3 liters with 2 milliequivalents sodium per kilogram per 24 hours, which makes it about 150, which makes a full liter, 1 liter of normal saline. 1 liter of normal saline has 154 milliequivalents sodium chloride, which gives the patient the maintenance requirement, the average patient during the 24 hours. If there is loss, there is deficit, you have to increase this amount. This applies to electrolytes and to water fluids. How to monitor the response of the patient to your IV fluids to know you are on the correct way. You monitor the whole clinical picture. Again, we go systematic. If the patient is thirsty, this means that he is inadequately hydrated. This is symptoms. Signs, general condition, if he still looks dehydrated, this means that he is not adequately hydrated. If there is tachycardia, he may be hypovolemic. And one of the best monitors of the hydration status is
mucus variance.
mucus variant. كيف تقيسه هذا؟ mucosa الهايدريشن ما قلنا he will look dehydrated يعني he will have dry mucous membranes. Urine output. Urine output. هذا هو this is the main tool of the ICU doctor to monitor the hydration of the patient. How much urine output we need to see, how much you want to, how much the normal urine output. Normal urine output, how much? About 1 mil per kilogram per hour, or 1 mil or 1 mil per minute for the adults. This will make 1,500, almost. 24 ساعة ب 60 دقيقة. Altogether, it makes 1.5 liters. This is the normal requirement of fluid for an adult. For children, you know how to calculate the first 10 kilograms, 100 per kilo, the next 10 kilograms, 50 per kilo, and then 20 per kilo for the rest. So, if there is no dehydration and the patient is not has no deficit, you need to give them 1.5 liter, which means you want to خلط ما بين fluid requirement and the urine output. A normal patient, which is well and hydrated and he is not dehydrated, you expect to have a urine output of about 60 per minute, or 1 mil per kilo per minute, which makes it 60. What is the minimum urine output you can allow? 30, half of this. You want the patient to have at least half a mil every minute urine output, 30 per minute, which will make about 500 per 24 hours. When we call it oliguria, when it is less than 100 ml per 24 hours. If the patient has low urine output, you increase the fluid replacement until you end with good urine output, at least half mil per minute. If you give fluid replacement and the patient is still not responding and the urine output is very low, then you give him what is called a challenge, fluid challenge, just to make sure for the last chance that his kidney function is okay, and hopefully he will respond to this fluid challenge. If he responded and get urine out well and good. If he did not, then he might be going into renal failure. Then you have to check his renal function and consult your nephrologist and start managing him as a case of renal failure. But usually, you replace and the patient will respond by increasing urine output. Operative treatment might be needed in cases of suspected strangulation or well-established strangulation or perforation and peritonitis. When we come to operative treatment, then the main challenge is the affected segment. Is it viable or not? The main challenge is to judge, is this segment of bowel which was strangulated inside a strangulated hernia or something else, is it still viable or already dead and should be resected? This is a big decision by the surgeon when you operate a case of this. We start by relieving the obstruction as soon as possible. If there was a hernia, we open the constricting neck of the hernia and let the bowel recover. We wait for a few minutes. We wrap it in warm saline gauze and give it a few minutes to recover and then reassess. What are the signs of healthy, viable bowel? The pink color, shiny pink color, and peristalsis. When we tick it, it will move with peristaltic movement, and we can palpate the vessel, the mesenteric vessel between two fingers in the mesentery of that lobe to feel the pulsation. If the bowel color is doubtful, it is violet and it is not pink, completely pink, and there is no peristalsis and no pulsation in the mesentery, or it is completely gangrenous, established gangrene. So either with established gangrene or with high suspicion of non-viability, we accept. We accept and anesthetize. If the affected bowel is very long segment, or all of the bowel is affected, then resection primarily is not a practical decision. We do what is called second look. We close the abdomen and we come back after 48 hours, hopefully to see it recover completely, or establish gangrene, and then we have to reset. This is the picture on the upper left. On the lower two sides, it looks healthy. The upper left is a bit congested, and this is the one we like to give it some chance to recover by covering it with warm saline pack. The right side upper and the left side middle are completely dead, clearly dead. So we assess, give the chance, and then decide. If we have to resect, how to anastomose? Small bowel can be anastomosed primarily, no problem. Large bowel, if it is on the right side, again, we can do a primary anastomosis. The left side lesions, usually safer to exteriorize it as stone and to do later re-anastomosis at later stage, 6 weeks later. Why this difference? Because of the bacterial content and the vascular supply. The more you go distally in large bowel, there will be a large bacterial content, so the contamination is much more, and the blood supply is poorer, more distally in the inside. So in these cases, we resect the pathology or the dead segment, and we exteriorize both ends as stoma. One of them is a real stoma, and the other is called mucus fistula, because there will be no stool from the distal one. If the distal one is short and cannot reach the surface, the abdominal wall, then we close it and hook it to the pelvic wall, what is called Hartmann procedure. The conservative treatment, as we said, suck and breathe, decompress, give IV fluids, and observe. As long as the patient is okay, no signs of strangulation, and the patient is well, we can continue conservative treatment for a few days. This is the closed loop obstruction like volvulus. Also, the closed loop obstruction applies to left-sided colonic lesions with patent ileocecal valve. When the ileocecal valve is strong and patent, and there is a lesion distal to it, then the part between the lesion and the valve is a closed loop. And the cecum is at risk of this dilatation and perforation at one stage perforation. If the cecum on X-rays, the diameter exceeds 10 centimeters, it is at risk of perforation. This is the adhesive obstruction. Adhesive obstruction recovers spontaneously on conservative treatment in most of the cases. Don't rush to surgery in adhesive obstruction, because any new surgery will increase the chance of adhesive obstruction in the future. So we give it full chance before we intervene surgery. As long as there are no symptoms or signs of strangulation, we can continue our conservative treatment. This is the strangulation and closed loop. Volvulus. Volvulus is twisting the loop of bowel around its mesenteric axis, and it results in strangulation soon. Most commonly seen in sigmoid colon and sometimes in the cecum. It is also precipitated by malrotation and incomplete rotation of the bowel. You know the embryology of the bowel, the cecum and colon, right colon moves across the abdomen. So sometimes there is incomplete rotation, and this will end with redundant colon, which is be more exposed to volvulus. This is the sigmoid volvulus picture, clinically and radiologically. Radiologically, it gives what is called the picture of coffee bean sign. These two limbs of the sigmoid colon with the partition in between for the wall of the two parts will give this appearance of the coffee bean. When you operate on this sigmoid volvulus, it's quite huge. It presents with sudden severe colicky abdominal pain with distension of the abdomen, and it shows clearly on X-ray or on CT. The most important is to treat before strangulation, before gangrene happens, which will end with peritonitis. Cecum also can have this volvulus. In treatment, we can try to decompress and detwist the sigmoid volvulus with a well-lubricated rectal tube. خليكم معنا انتم اللي عم تحكوا ورا. You can insert a well-lubricated rectal tube and try to manipulate to de-twist and decompress this blood vessel. And in many cases it succeeds. When you succeed, you will see the result in front of your eyes. There will be a gush of air and stool when you succeed in relieving this problem. Last year, I did a case in Malawi, in Africa. I was on a mission there. There was a patient with huge distension. أحمر من هذا في البطارية. هي جديدة شلون؟ أعطيه بطارية. سامعيني اللي ورا؟ I was talking about a case which I did last year. An African patient was hugely distended. We managed to reduce. لا يبدو أن عديد بطاريته لأنه حمراء. After that, we prepared the patient and we used electricity. This is the main idea. الرابع هيك لما الاستاذ يسكت شوي بصير يحكي.
حسب السبب ما كان طالب هو ما كان